Hello, everyone. Welcome to another case series. We'll be discussing a total of 14 cases involving pancreas and their radiology findings. My name is Dr. Jeff. Starting with the anatomy, this is an ultrasound exam trying to show the anatomy here. This is the anterior abdomen of the patient. That's where the probe is, and we are scanning anterior posteriorly. This shadow here is vertebral body. Going forward, this is the labeled image of the same patient. Here we can see this is the head of the pancreas. This is the body of the pancreas, and the vascular structure, which is immediately behind the pancreatic neck here, is the aorta. The vessel, big vessel next to that on the right side of the patient is the IVC. Be right behind the pancreas, running with the pancreas posteriorly is the splenic vein, and that vein drains into the portal vein with the confluence with the SMV right here. The other finding that is important is SMA is present between the pancreatic body behind the splenic vein and anterior to the aorta. A little more detailed image of the pancreas. Here we see the left lobe of the liver. This is the anterior of the patient. This is the posterior side of the patient. And here we see the vertebral body shadowing is present. We can see the aorta right here, IVC right here. Our vessel is draining anterior to the aorta into the IVC. That will be a renal vein. Splenic vein we saw earlier, right behind the splenic vein is SMA. Between the splenic vein and aorta, going back to the head of the pancreas, a tubular structure without discrete flow, it will be a CPT. Hepatic artery can also be seen right here, and a tiny vessel anteriorly confluence of the splenic vein with the SMV. A tiny vessel is GDA. Case number 2. This patient presents with intermittent abdominal pain. An MRCP was performed. A single MRCP image is noted. This is a MIP image, and we can see this is DPD that flows down here. And this is the main pancreatic duct, which goes here and crosses over the CPT. A tiny dilatation right before it drains into the duodenum. This structure is the duodenum. This sign is called crossing duct sign. Main pancreatic duct is crossing the CPT, and this is consistent with pancreatic divisum. And this tiny focal dilatation of the pancreatic duct draining into the minor papilla is called centaurinocele. This drains at the pancreatic duct drains at the level of minor papilla. CBD drains at the regular position of the major papilla. Crossing duct sign. Pancreatic divisum increases the risk of pancreatitis. And in asymptomatic patients, there is no treatment necessary. But in symptomatic patients, for example, if they have a recurrent pancreatitis, symptomatic patients can benefit with stenting or minor papillectomy, decompresses the pancreatic duct and balloon dilatation. But in asymptomatic patients, no treatment is needed. On MRCP, to improve the quality of the images, we can also give them secretin that increases the flow of pancreatic enzymes into the main pancreatic duct and makes the duct look more prominent. Which hormone is normally produced in the duodenum to stimulate the pancreas to produce bicarbonate rich fluid? The answer to this question is secretin is the hormone that is produced. Case 3, we see three images. This is an axial CT contrast enhanced image. Here you can see the kidney right here. We see the spleen right here. And then there is pancreatic parenchyma right here. And in the pancreatic tail region, there's this hyper enhancing mass. It enhances more than the background pancreatic tissue. So that is concerning. It could represent a splenosis or a neuroendocrine tumor. This patient underwent a gallium dotatate scan, increased uptake in the spleen, which is physiologic, and also increased uptake into the pancreatic tail mass lesion. This patient also underwent RBC study. RBC study shows increased uptake in the spleen, but no uptake at all in the pancreatic tail mass. This is consistent with a neuroendocrine tumor, because if it was a splenosis, it would take up radiotracer on RBC study. A neuroendocrine tumor are mostly non-functioning tumors, so they are detected just because of their mass effect or incidentally detected. Some cases are symptomatic because of the functioning tumor. The most common kind of the functioning tumor is insulinoma. So in those cases, the patient will have high insulin production and have recurrent hypoglycemias. In those cases, the tumor is usually less than 2 centimeters. Otherwise, Non-functioning tumors are detected when they are bigger in size, either cause symptom because of the local mass effect or are incidentally detected. Treatment for neuroendocrine tumor is curative surgical resection. Pancreatic neuroendocrine tumors are associated with syndromes, MEN1, VHL, and tuberous sclerosis are the three syndromes that are associated with pancreatic neuroendocrine tumors. Case number 4. This is a young female, 20s to 30s in age, non white, presented with abdominal distension and heaviness in the abdomen. Here we see large, predominantly solid, with central cystic component enhancing mass lesion at the level of the pancreatic body and tail. This is a well encapsulated tumor. The central cystic area can sometimes have hemorrhage or calcification. Based on the demographic of the patient and the imaging appearance of predominantly solid mass, the findings are suggestive of a solid pseudopapillary tumor of the pancreas. They are predominantly seen in young females who are non white. Most of these tumors are benign and only 15% are malignant. Case 5. This is an abdominal radiograph, the multiple densities in the upper abdomen. And if you try to draw a margin around these densities and try to determine what shape this structure is and where this calcification is, this corresponds to the location and shape of pancreas. This patient underwent a CT scan. The CT scans shows diffuse calcification throughout the pancreatic parenchyma. There is associated pancreatic parenchymal atrophy. This imaging presentation with diffuse atrophy of the pancreas and calcification is consistent with chronic pancreatitis. And that the imaging findings are dilated main pancreatic duct and side branches, atrophy, and calcifications. The cause for chronic pancreatitis in developed world is chronic alcoholism, and in underdeveloped countries, malabsorption. Chronic pancreatitis can increase the risk of pancreatic adenocarcinoma by 13-fold. And when chronic pancreatitis is so bad that in addition to the exocrine pancreatic insufficiency, there is damage to the pancreatic parenchyma to such an extent that the patient does not produce enough insulin, the patient develops diabetes mellitus. And when the patient has diabetes mellitus, secondary to chronic pancreatitis, the increased risk of pancreatic adenocarcinoma is significant 33-fold. Case 6. The patient presents with diffuse abdominal pain and fever. This is a coronal CT image, contrast enhanced, which shows heterogeneous fat stranding all around the pancreatic parenchyma, and pancreas is diffusely edematous. This is the pancreatic parenchyma, which is enhancing, but the pancreatic parenchyma in the head and neck region is not enhancing if you compare it to the pancreatic tail region. Inflammatory changes with non enhancing pancreas is suggestive of necrotizing pancreatitis. Sometimes immediate diagnosis on immediate presentation is difficult because diffuse edema reduce the attenuation of the pancreas. Oftentimes, a follow-up exam at 72 hours is considered to be more sensitive and more accurate in diagnosing necrotizing pancreatitis. And if the post-contrast exam shows attenuation of the pancreatic parenchyma less than 30 ounce per unit, that is suggestive of necrotizing pancreatitis. That means that pancreas is not enhancing with IV contrast. Necrotizing pancreatitis can get complicated with infection in approximately 40% of the cases. It's difficult to diagnose infected necrotizing pancreatitis, but if there is foci of air within, it is highly suggestive of superimposed infection. Lack of air does not exclude infection though. It's important to identify necrotizing pancreatitis because it has a very high mortality up to 15%, and it is even more important to identify if there is superimposed infection because the mortality jumps from 15% in sterile necrotizing pancreatitis to 40 to 50% in infected necrotizing pancreatitis. Next case. So this patient presents with diffuse abdominal pain, a multimodality workup done here. So this is an axial CT after administration of IV contrast. There's diffuse sausage shaped thickening of the pancreatic tissue with no distinct peripancreatic inflammatory changes. In fact, the fat plane between the pancreas and the bowel loops anteriorly is also very well maintained. This is the post contrast study, and there is this edematous diffuse thickening of the pancreatic parenchyma. Again, we see the fat plane with the adjacent structures is maintained. There is no peripancreatic edema or enhancement. This is a DWI weighted image and shows diffusely increased signal intensity within the pancreatic parenchyma. Putting all these things together with sausage pancreas, no peripancreatic inflammatory changes, and restricted diffusion, these findings are suggestive of autoimmune pancreatitis. Another finding which is not seen on this exam is diffusely narrowed main pancreatic duct, also known as duct penetrating sign. When there is diffuse sausage shaped pancreas, the pancreas is diffusely edematous. The inflammation causes this local mass effect on the main pancreatic duct, causing it to diffusely narrow. There is no abrupt transitioning, but the entire pancreatic duct gets narrowed. The treatment of choice for autoimmune pancreatitis is corticosteroids and immunosuppression. So this is a CT after administration of IV contrast. This patient presented with acute trauma, road traffic accident, and as we can see here, this is the pancreas which shows normal enhancement, except here in the body and tail region, there is this wedge-shaped area of hypo enhancement, and then distally the tail is enhancing normally. Adjacent to the pancreatic parenchyma, there's this fat stranding, and this dark line of hypoenhancement is extending through and through the pancreas. So these findings are suspicious for pancreatic laceration. And in terms of once we know that there is pancreatic laceration in this particular case, it's important to identify if the main pancreatic duct has been hurt. Evaluation of that is difficult on the CT. ERCP or MRCP are the next modality of choice for further evaluation. In terms of classifying the laceration, if it is partial thickness, it's called a laceration. If it is full thickness, it's called transection. And in terms of main pancreatic duct involvement, if there is transection, the main pancreatic duct is also injured. ERCP is better for evaluation of pancreatic duct laceration involvement, and in those cases, most of the time, surgery is the treatment of choice for main pancreatic duct is when if the main pancreatic duct is disrupted. So this is a patient who presents with diffuse abdominal pain and has been having difficulty eating anything. When the patient is laying down, the pain gets worse, and this symptomatology has been present for around 4 weeks. Based on the history and the imaging appearance, we'll try to make a diagnosis. This is a CT, axial CT after administration of IV contrast. Here we see the pancreas, and around the pancreas there is this well marginated fluid collection with a very well defined capsule. So this is a pancreatic pseudocyst, likely secondary to acute edematous interstitial pancreatitis. If we aspirate this fluid is high in amylase levels and is low in CEA levels. It's important to identify lack of necrosis. Presentation is usually 4 weeks or longer. There's a very popular table to classify these fluid collections. So if there is peripancreatic fluid collection associated with interstitial edematous pancreatitis and it is less than 4 weeks old, it's called acute peripancreatic fluid collection. If the fluid collection is greater than 4 weeks old, it's pancreatic pseudocyst. In terms of necrotizing pancreatitis, if the collection is less than 4 weeks old, it's called acute necrotic collection. And when the duration is more than 4 weeks, it is called as walled off necrosis. Case number 10. This old lady in her 60s presented with non-specific symptoms, and this is a CT that was acquired. This is a non-contrast CT that somehow limits evaluation, but we can look at a few features which are characteristics. A multicystic mass in the pancreatic head with central stellate calcification. In elderly female, greater than 6 cysts clustered in the pancreas, and each cyst less than 2 centimeters in size. And none of these cysts, if they don't show communication with the main pancreatic duct, the diagnosis is serous macrocystic cystadenoma. These are called grandmother lesions because the age group that it involves. The treatment is conservative because of the low malignant potential. Surgery is only indicated if the patient has symptoms secondary to just the mass effect of the tumor. Also, if the tumor grows rapidly in size. So this patient is a middle-aged female in her 40s and presents with abdominal pain. This is a contrast enhanced CT, and there is this cystic, well marginated mass with unilocular cystic appearance, and then there's this thin peripheral calcification. Considering the age, unilocular cystic appearance, and peripheral calcification, finding is consistent with mucinous cystic neoplasm. These neoplasms tend to have a more aggressive course than the serous cystadenomas. The treatment of choice in all these cases is surgical resection. The 5 year survival in non invasive cases is 100%, but it drops to 60% if the patient has invasive features. Case number 12. Here we have this contrast enhanced axial CT, and there is this diffusely dilated main pancreatic duct. There is associated pancreatic parenchymal atrophy right next to it. Diffusely dilated main pancreatic duct, and this patient is elderly in his 70s and 80s, and sometimes they can also have peripheral calcification. All these findings point towards main duct intraductal papillary mucinous neoplasm. Main duct intraductal papillary mucinous neoplasms tends to have higher malignant potential than side branch intraductal papillary mucinous neoplasm. Worrisome features are if the diameter of the tube is greater than 5 to 9 millimeters. The high risk features are if the dilated main pancreatic duct is greater than 10 millimeters and has a solid mural nodule. So these are the things that you should we should be watching out for in terms of risk stratifying our patients. They are male predominant, and some people also like to call it as grandfather lesion because of the age group that it involves. And around 60% of them have a malignant potential. Next case number 13. So this patient has history of recurrent lower respiratory tract infection, and as you can see, this is a CT, axial CT of the upper abdomen. If you pay attention to the abdominal wall, there is diffuse atrophy of the muscles of the abdomen. Respiratory symptoms were there, and then there is this if you look at for the pancreas, which is we are supposed to see right anterior to the splenic vein, we don't see it, mostly replaced with fat. Overall findings are suggestive of cystic fibrosis. Cystic fibrosis can have this inspissated secretions that can chronically obstruct the main pancreatic duct and then lead to complete parenchymal replacement with fat and fibrosis, resulting in pancreatic insufficiency. And these patients tend to be malnourished as well, as we can see in this case. In this case, the patient's body habitus looks very malnourished. There is diffuse sarcopenia. Last case number 14. So this patient presents with abdominal pain, and this is a coronal CT of the upper abdomen after administration of IV contrast. And interesting thing here is we see this dilated CBT, and right next to the dilated CBT, there's another tube. This is the main pancreatic duct that is dilated. So this is called a double duct sign, and this is suggestive of an obstructing mass lesion at the level of the ampulla. So that mass lesion can be a periampullary carcinoma or a pancreatic carcinoma. Usually, pancreatic adenocarcinoma is hypoenhancing to the adjacent tissues. Periampullary carcinoma can have variable enhancement pattern. So, in terms of pancreatic cancer evaluation, there are a few findings that make the pancreatic cancer unresectable, and those findings are greater than 180-degree encasement of the SMA and the celiac or the celiac artery. If any of these vessels are uh, encased for more than 180 degrees, that makes them unresectable. Other vessel involvement like splenic artery and splenic vein involvement does not make them unresectable. This is the last case. Thank you so much for attending.